Now, in order to treat these, again, we must work through the axis of movement. Lock-in in this area is really not feasible, nor is it absolutely essential. Now, let's assume that I'm treating an extension and right rotation dysfunction. The patient's position will be exactly the same, okay, and my hand position at the back will be very similar. But now I'm going to have to stabilize the lower vertebra rather than just palpate. And my stabilization will be in the opposite direction to the way it wants to move. So if I'm doing extension and right rotation, then I will be preventing the vertebra from coming down and swinging to the right. So any handhold that you can use that is effective for doing this is fine. I tend to use the heel of my hand. So I'll be pushing down and to the right on the spinous process. So I'll extend and right rotate, and there's the technique there. Again, remembering to use the hold, relax, oscillate for pain, and a prolonged stretch or a strong oscillation for mobilization. Alternatively, I could treat the extension dysfunction using a glide, using the arthrokinematic, in which case I'll position the patient at the barrier to movement, and then instead of stabilizing the lower bone, I'll stabilize the superior bone in this position and glide the lower bone superiorly and anteriorly along the plane of movement so that I regain the movement at the joint, like so. So all of the pressure is being put through my left hand while my right hand is simply stabilizing. For flexion dysfunctions, then we'll simply do the reverse. We'll take it to the flexion, right rotation barrier. And now I want to prevent the spinous process from tipping upwards, so I'll hold it down, and again stopping it from swinging to the right. So again, I'll be in this position, pushing down on it and to the right now in this position, and then flex to that segment, right rotate, and mobilize like so. The arthrokinematic for this particular movement is very difficult to produce and is usually not worth the effort. Thanks. These will tend to take care of the asymmetrical restrictions. There are other techniques, of course, as there always are. You can lay them prone and use your hand as a block. Unfortunately, it tends to injure your hand, and there's not a lot of point in getting your patients better when you're becoming disabled as you do so. For the symmetrical restrictions, we can, of course, treat them in the same manner by doing bilateral asymmetrical mobilization techniques, or we can try to treat them as a symmetrical restriction with a symmetrical technique. So for flexion, hands up on the back of your neck again, it's exactly the same position, but this time I really only have to hold the spinous process down rather than also prevent rotation. So in this position I shall flex down to the segment through the arms again, like so, and then simply pull down on the arms. There. For extension, stabilize by holding the spinous process up, there, and I can extend, or I can extend and then glide the inferior vertebra forwards through the plane of the joint. The final symmetrical technique that works really quite well, particularly with simple flexion extension dysfunctions, is traction. And we're going to do a local traction here. Specific traction isn't really possible, nor is it particularly, it's not practical and it's not really possible. So we're going to do a local traction technique here. And because we're in this upper part of the spine, we will fix the inferior vertebra as we lift the superior vertebra off of it. So the traction tends to be confined to the levels above that segment and that segment, and restricted in the areas below the fixation. So in order to do this, we need a sandbag or a very tightly wrapped up towel. You need the bed up to a good height where you're comfortable and you can fix this. The sandbag will go against the lower vertebra of the segment that you're dealing with. Come back a little bit on the bed. Now we want the patient in exactly the same position that we were in when we were stability testing traction. So sandbag here, patient right back against the bed, and you'll fix the sandbag with your chest, like so. The arms go in exactly the same position, uncrossed, there, and then we'll have the patient lean back on us, head back, and then the traction is applied by simply squeezing your arms together, this way, not lifting her off the bed. And the sandbag provides the counter traction, or actually you provide the counter traction through the sandbag. Now this is a comfortable enough technique and it can be done over a fairly prolonged period. I'm panting because I'm not in shape, but I'm sure the rest of you can be doing this quite comfortably. Okay. Essentially then, we've looked at the examination and treatment of the cervicothoracic spine, and again we've looked at stability, hypomobility and hypermobility, and we've looked at some of the techniques that are available to you for treating this region. Thank you.